Good afternoon, everyone. I am Dr. Sanjay Goyal, HOD of Hematology and Transplant Immunology at Global Reference Lab Metropolis Healthcare Limited, Mumbai. And I welcome all of you to today's MedTalk session with Dr. Abhay Bhave. MedTalk, under the aegis of Metropolis Foundation CSR arm of Metropolis Healthcare Limited, is an initiative aimed at bringing together the medical community, especially our young and aspiring medical students, to learn from leading voices across the different medical specialties. Through these sessions, we hope to share the knowledge, spark the new ideas, and keep the spirit of medical learning alive. Our distinguished speaker for today, Dr. Abhay Bhave, is a renowned hematologist with over 30 years of clinical experience and a passion for academics and research. He completed his post-graduation from CMC Vellore and went on to pursue a fellowship at Westmead Hospital in Sydney, Australia. We are in an era of remarkable transformation in the oncology, especially in hematological malignancy, where advances in immunotherapy, targeted agent, and cellular therapies are redefining the patient outcomes. Dr. Bave will be sharing his valuable insight on revolutionizing hematology cancer treatment, new frontiers, and future direction. We are really looking forward to his insights on his latest development and the futures of hematology. After Dr. Bhave's presentation, if you have any questions for Dr. Bhave, please feel free to type that into the chat box. We'll be happy to take them up during the discussion. Now, I welcome Dr. Bhave to deliver his talk. Welcome, Dr. Bhave.
Thank you very much, Dr. Gohil, and thank you very much, Metropolis MedTalk platform, for this opportunity to interact with the audience. So with your permission, I'll share my slide deck. I'm hoping I'm audible and my slide is seen. Okay, so thank you once again. The discussion today, this afternoon, over the next 35 minutes is going to be on revolutionizing hematological treatment to see whether we've got new frontiers and future directions. Why have we chosen this topic? We have chosen this topic because globally, hematological malignancies represent a major public health burden, with almost 1 in 5 cancer patients in the world being hematologically cancer affected. But having said that, I must also tell you that in that year preceding to the last, 10 out of 30 newly FDA approved anti-cancer agents targeted blood cancers, marking an unprecedented innovation with multiple first-in-class therapies. So when I talk of hematological cancers, I am including both acute and chronic leukemia, lymphomas, and myeloma. And while we use conventional therapy, it does have major challenges, such as effectivity and sometimes relapse, resistance to ongoing therapy, toxicity of especially chemotherapy, and cost not only of the chemotherapy, but the side effects of chemotherapy and maintaining the adverse events of chemotherapy. Therefore, as a clinician and as my patient sitting in front of me, what's my goal? It's to improve survival and to improve survival with a quality of life. But then how do we go about this when conventional therapies are fraught with challenges as discussed? So we need better diagnostics to enable us to do precision or personalized medicine. We need better treatments and we have immunotherapies. And all this along with something like an advanced technology such as AI or ML, machine learning tools, we can give faster, more accurate diagnosis and more effective and targeted therapies. In today's discussion, my hero is going to be diagnostics and all the laboratories which help us diagnose problems. Because it is only through diagnostic events that we are able to make clear-cut decisions about therapies also. And I'm hoping to impress you as time goes along. So whenever we have better diagnostics, better treatments, we are going to have better outcomes with a better quality of life, and possibly more better survival rates. And I'm hoping that will answer the third question that was posed above. Now, since the topic is revolutionizing treatment schedules, what is a revolution? Revolution is something that completely changes something to something much better. That's called revolution. Let's see whether we were able to do that in hematological cancer care. So, traditionally, we have been diagnosing cases of hematological cancer on the basis of morphology. And we have been instituting cytotoxic chemotherapy. It's a short term for chemical therapy, which used to just carpet bomb the bone marrows, carpet bomb diseases, and hope you come out of it well. We had at that time limited prognostic markers. Therefore, it was almost a situation of one size fits all treatment. Now, over a period of time, and I would say the last 2 decades, things have changed quite a lot. Modern revolution has given us better molecular and genetic profiling. It has given us comprehensive biomarkers which are very sensitive and specific in order to be able to diagnose and look for options of treatment. And with that came targeted therapy and cellular therapies, thanks to the pharma coordinating with research groups to be able to make targeted therapies for us clinicians to use, the end benefitor being the patient. So, integration of such genomics, immunotherapy, and real time monitoring is redefining outcomes in hematological cancers. And I extend this to leukemias, both acute and chronic, to lymphomas and myelomas, which form the bulk of hematological cancers that we are discussing. I must tell you, our laboratories have already been giving us very good diagnostic services in the form of fluorescent in situ hybridization, polymerase chain reaction, immunophenotyping, also called flow cytometry, and through histopathology, we were getting immunohistochemistry. These four were brilliant modalities for us to be able to diagnose patients. However, we realized that many patients in one group would behave differently. Everyone would not respond in a similar manner, which for us clinicians meant there is something beyond these tests which probably we are not looking at, but which is making a difference to the patient's response and outcomes, and therefore relapse or going into deep response, or even for that matter, functional cure. So, what was that additional that we were missing out? And that's where the revolution comes in for today's diagnostics. Now, if I have to treat better, we need better diagnostics. And over the four which I've already mentioned to you, we need something that would give us diagnosis earlier and more disease specific biology identification. So we could understand the biology of the disease to see, can we customize the treatment to our patient, which is called precision medicine or individualized care or personalized care. Towards that, we had next generation sequencing. It's available to us for more than a decade now, where we were able to do genetic profiling, genomic profiling to identify certain specific mutations that are diagnostic of the disease process and can also act as a target which might help me to change my treatment and improve outcomes. It might also help me to monitor the disease process to see whether that genetic mutation which initiated the disease, has it been quenched, has it been removed. Towards this, from the NGS sequencing for, say, myelodysplastic syndrome, we got SF3 beta 1, and research organizations and pharma gave us luspatercept, which shows a good response. There was identification of IDH1 and IDH2, which we now have inhibitors against, and that makes a lot of difference in AML. Likewise, FLT3 is an adverse prognostic factor in AML. Today, thanks to that, we are able to use FLT3 inhibitors, which has improved the outcome of acute myeloid leukemias, especially those who are relapsing early. We are now able to take them longer and including doing very well post-transplantation. We've also got NPM1 and KM2A, which are two genetic markers against which now pharma has given us a drug called menin inhibitors. In addition of that, has helped to bring better disease control. And these genetic profiles have also given us the ability to understand how bad can be the disease. TP53 is a notorious genetic mutation. in its homozygous form is the worst. It's a gatekeeper to cancerous changes, and it can give rise to different types of cancers, not only blood. But its present augurs very poorly for our patient, and we know that this patient is not going to do well. And therefore, something like bone marrow transplantation comes up on our list when we see such mutations in the patient's genetic armamentarium. We now also have liquid biopsies. That means we can look at circulating tumor DNA or circulating tumor cells from blood samples, mind you, not from bone marrow. And both NGS and liquid biopsies can be done from the peripheral blood. It tells us about the tumor's genetic makeup, how to monitor it, see if it's increasing, that means it's progression, in spite of there being no symptomatology, and also tells us about minimal residual disease so that we can pick up early relapses if there is one. While we use this more often in patients with solid tumor, we are using this in lymphoma and myeloma. It's going to be the future in the next few years. So therefore, in that situation, maybe doing bone marrow examinations will be passé, and we'll be only doing liquid biopsies and NGS for such patients. That time will come. And of course, artificial intelligence and machine learning tools has helped us to look at images, including peripheral smears, by the way. Don't worry, the pathologist will have no problem. But machine learning tools will look at peripheral smears, bone marrow examinations, as long as we fit in very good algorithms into the AI or the machine learning algorithm. They'll help us to interpret the data far better. And flow cytometry is becoming more and more complex. We're using more and more reagents. So the plethora of reagents that are used sometimes can be a little bit mind-boggling. But AI, if it's filled in with the algorithm, will be able to analyze and diagnose far faster and better difficult cases of hematological malignancies. So more accurate, more cost-effective, less time-consuming, and more individualized answers can come out of AI with machine learning tools. And to top all this, if we can now start detecting minimal residual disease or measurable residual disease, it's become one of the brilliant criteria, not only for finding out how well we have done in terms of therapy, but is the disease coming back? So it is good for monitoring for disease response and also as a strong predictor for outcomes. Is the disease coming back or not? We can do this by next generation sequencing, flow cytometry, liquid biopsies, and with polymerase chain reactions. The clinical impact is going to be huge. We can do treatment adaptation and do transplant decisions. And I'm going to give you some examples as we go along. So to my mind, these newer diagnostics are game changers for me as a hematologist in the field when I practice, because it has changed the way I'm going to look at disease process. And my patients are going to be far better because of the availability of these. Now, through modalities such as flow, that is immunophenotyping, FISH, fluorescent in situ hybridization, cytogenetics, and RT-PCR for BCR-able by PCR methods, we could pick up, say, in CML, the tyrosine kinase abnormality that was at the translocation of 922. And through pharma, it revolutionized the way treatment was given for CML. When I started, we had to give chemotherapy to patients of CML. We would take them up for transplant, and we would have 30% of patients dying because of CMV reactivation, and young people we would lose during transplantation. Today, it's replaced by a magic bullet, and that is called as a TKI, tyrosine kinase inhibitor. We've got 4 generations of tyrosine kinase inhibitor, and CML today survive like normal people. Now, if that's not revolution, nothing else is. In the Philadelphia positive acute lymphatic leukemia, we have reached a stage that we can use a TKI inhibitor, and if you combine it with an immunotherapy such as blinatumomab, we can get 95% control of disease, which no chemotherapy can give. And this is the way our treatments are progressing. If cytogenetics picks up deletion 5q in myelodysplasia, then we can use lenalidomide, a simple tablet which is not chemotherapy, and we get brilliant responses between 60 and 80% in these patients where the hemoglobin comes to normal. Translocation of 15-17 by RT-PCR diagnoses APML, and the treatment today for that is non-chemotherapy. Arsenic trioxide with ATRA, all trans-retinoic acid, and we get brilliant responses, and we can use the same RT-PCR to be able to look at disease monitoring to see, have we eliminated the disease clone completely, are we gone into a functional cure? And if they go beyond 5 years, it is considered curative. We also got BCL2 inhibitors like venetoclax in acute myeloid leukemia, where we started using azacitidine with venetoclax, non-chemotherapy, to work brilliantly in patients with AML. And we are using the same venetoclax in CLL in combination to get finite therapies. Also, checkpoint inhibitors were given to us through these diagnostic facilities, which are huge in Hodgkin's lymphoma, but huge, or should I say, huger in solid tumors. I'm using it now in Hodgkin's lymphoma. Nivolumab is become a brilliant option in high-grade disease. That is when the disease is stage 4, 3 or 4, including in older patients, including in younger patients, with brilliant responses when it's combined with chemotherapy. Thanks to bioengineering, which is an arm which was extremely important for us to do drug delivery, and we got monoclonal antibodies. We had CD20, which is rituximab against various types of lymphomas and CLL. CD38, targeting CD38, that is daratumumab and isatuximab, which has become first line of treatment in myeloma. Against CD79B, polatuzumab, which is a brilliant drug used in advanced stage disease of diffuse large B-cell lymphoma, which is a non-Hodgkin's lymphoma. It's used upfront now. We've all heard of CAR-T. It's been discussed widely in the public domain, in newspapers and in journals. And this is a brilliant new immunotherapy which has come up, which is against CD19 in acute lymphatic leukemia and lymphomas. And it's also going to be used in chronic lymphatic leukemia, and against a specific antigen called BCMA against myeloma. Then there are bispecific antibodies, blinatumomab, which I told you about in ALL, teclistamab, elranatamab against myeloma relapse cases, and talquetamab against a new site on the myeloma cell, the GPRC5D, which is also a brilliant bispecific. Thanks to engineering, we've also got antibody drug conjugates, such as brentuximab vedotin, inotuzumab, and gemtuzumab, which have made a huge difference in Hodgkin's lymphoma, acute lymphatic leukemia, and in acute myeloid leukemia, respectively, changing outcomes in these patients. These drugs actually came into market in trials in relapse cases of individual disease processes, and they have had such good responses that they are rapidly chasing and breaking down frontiers to come into frontline therapy. And soon, maybe 3 to 5 years down the line, they will be the first line treatment, and there might be no chemotherapy in the future. We're also going to get off-the-shelf allogeneic CAR-T and NK cell therapies. And India itself, through Atmanirbhar Bharat, mRNA-based cancer vaccine platforms have been made, and soon we'll be able to offer these to our patients, which was an initiative by DBT and BIRAC through the Prime Minister's office. Now, I said about artificial intelligence. Artificial intelligence in hematology has got huge applications, and I don't think it's going to be a replacement. I think it's going to be a great addition to us to be able to do things better. I've written down 2 columns of the benefits of artificial intelligence for us, but may I just show you what it's going to do in the future? It's going to give us, it's going to be able to be applied in blood smear examination, disease prediction models, genomic and proteomic analysis, coagulation disorders, integration with point of care treatments, and it is going to give you models that can explain to you and be able to use targeted therapy for decision making and real-time decision support. Now, the key benefits will be huge number, right from high precision of diagnosis to being able to give the right patient the right therapy. And it facilitates this clinical integration, and hopefully it will be seamless to be able to give the best line of treatment to our patients. Yes, it's going to come with plenty of challenges, but it is something that we can look at and make it our friend and try to improve it further. There'll always be a question of stem cell transplantation. I want to tell this audience that the only way to cure a disease process such as a hematological malignancy was and will remain in many cohorts stem cell transplantation. And to me, that's one game changer that is still there to stay in certain patients. Will our new treatments, which are revolutionary in itself, be able to muscle their way and game change the role of stem cell transplantation? Well, time will tell us. But we know that we are now going to unit families where there's only one child in the family, for the parents, and therefore getting a sibling donor as transplant donor is difficult. Thanks to modern technology, we can do haploidentical. That means father or mother can give to a child, or a child can give to father or mother. We can do for the older patients who otherwise were not fit for myeloablative transplants. We can now do reduced intensity conditioning transplants and still get benefit. So therefore, I feel that even transplantation is getting revolutionized. The conditioning regimens are better. The post care is better. The supportive care is much better. And that also to me is a revolution in the therapies rather than diagnostics. And today, we've got friendships happening all over. So we're going to have situations where we can combine the revolutionizing therapies such as bispecific and CAR T and use it for a period of time, get the patient into good control or good remission, and then transplant so that we don't have to continue the therapy further, and transplant, hopefully, will have a curative option. Therefore, sequential and these bridging approaches might be extremely helpful to us in the future to be able to get the disease into control and then have the best benefit of transplant, so that transplant will give us better curative rates. And it's a possibility that tomorrow, many of these revolutionizing treatments might avoid an allogenic bone marrow transplantation. We are doing this in trials in multiple myeloma, where we are trying to eliminate transplants, autologous transplant. But these diagnostics may also tell us that, look, your disease is going to be difficult. The current therapies available for this patient's genomics may not be appropriate, and therefore you'd rather do an allogenic bone marrow transplantation for this patient. So it might recommend to do an allogenic transplant for such patients. So this will always remain in the armamentarium of the management of hematological malignancies, even if newer and newer drugs come. Now, what has the role of diagnostics in monitoring, which I spoke to you about, minimal residual disease or measurable residual disease, did to me? Well, it gave me a concept called TFR, treatment-free remission. And we are doing this in CML, in myeloma, in non-Hodgkin's, and in CLL, that is chronic lymphatic leukemia. If we have achieved a certain level of depth of control, then we are happy to stop therapy, especially in CLL and in myeloma and in CML. Observe the patient and keep using that same modality of diagnostics to see, is the disease still in remission or is there a risk of disease coming back? And if there's a disease risk coming back, then we can always reinstitute therapy before the patient actually gets the disease or gets symptomatic. Now, isn't that brilliant? Rather than waiting for the patient to become symptomatic, and it might happen so fast that we may not get time to do the next treatment. And in terms of being personalized and in precision medicine, if we see that a patient is not doing well, then thanks to these diagnostics, we can actually pick up why the patient is not doing well. Is it because there was some resistant gene? Is that some gene which is not amenable to the therapy that is given? And that's where the role of pharmacogenomics came up. This gives us the concept of using pharmacogenomics in order to decide which therapy to give for the genes of that patient's disease process. And we saw this happening in CML and CLL. To give you an example, in CML, if you have got the T315I mutation, none of the generations of the younger generations of TKI will work. We have to go to specific treatment, that is ponatinib, or we have to use asciminib for these patients. And fortunately, both are available, and we can bring the disease back into control. I've got a 76-year-old lady who had the T315I mutation, and it's over a year and a half that she is still remaining in control. Otherwise, by now, she would have become an acute leukemia, and we would have lost her. Thanks to these diagnostics, thanks to these revolutionary methods of detecting why a person is not doing well, I was able to make a difference to that patient's life. There is gene editing. I have not had a single patient other than one thalassemia child, a major child who went for it, but I've lost follow-up with him. Otherwise, lentiviral vectors, and the CRISPR-Cas9 are becoming popular in the West, though not with us so much. There are ethical issues for its off-target effects and germline modification. We don't know what is going to be the long-term effect of such gene editing and gene therapy, but I'm sure this will also be a revolutionary treatment for those chronic processes such as thalassemia, hemophilia, and sickle cell disease, for which there is no specific therapy other than supportive, no curative form, but this might be one way of doing things. Like I told you, there are going to be challenges and barriers. There's going to be economic burden. Everyone may not be able to give it in their hospital, infrastructural gap. There might be ethical and regulatory challenges, especially as far as gene editing is concerned. We are worried, will AI be able to keep the privacy of our patient's data? Will it be inadvertently shared if someone accesses it? So a lot depends upon how our medical community is going to accept it, what's going to be the accepting by the patients community of these revolutionary processes, and will the insurance companies be able to give adequate remuneration for such use? So what difference has these modern diagnostics and treatments done for hematological malignancies? Overall, better treatment options, better outcomes, therefore, better disease-free survival, progression-free survival, and sometimes overall survival, and a better quality of life, because we have customized the treatment for that patient. We knew, rather than making an error and then finding the next one, we went upfront with the best option for the patient. So on a bad pitch, we send the best batsman. We didn't send the night watchman. We send the best batsman forward. So today we are combining therapies. Past it was chemo. Today we're doing chemoimmunotherapy. We are becoming less reliant on allogenic stem cell transplantation. We are some places using no chemotherapy, using combinations of IV and oral immunotherapies. And some places, I'm very happy to tell you, we are using all oral therapy, which is immunotherapy. An example of it is the TKIs in CML, the BTKIs, Bruton tyrosine kinase inhibitors in CLL and in certain lymphomas, and the BCL2 inhibitors such as venetoclax. And combinations of these are giving us brilliant responses. And with MRD being there, we can also get them off therapy. Yes, they will have different complications because they're immunotherapies. They'll be more costly, and we still have many patients who will not be cured, not because the disease is difficult. Sometimes the disease genes are difficult, yes, but because patients come to us late. So awareness in our patient population and community has to be improved, that if you've got odd symptomatology, come to the doctor earlier. What has this impacted my treatment today? Let me talk of myself. In diffuse large B-cell lymphoma, which is the non-Hodgkin's lymphoma, we were using R-CHOP for every patient. Today, we know that if it's a primary mediastinal lymphoma, we can use R-DIPOC with brilliant results, better than R-CHOP. If it's a type of ABC type of non-Hodgkin's lymphoma, we can use R-DIPOC. If it's a high IPI, that's the International Prognostic Index score, high IPI, R-DIPOC. Now, it's being challenged, but we know that it makes a difference for certain cohorts of patients. Polatuzumab, which I told you about, anti-CD79B, that with RCHP has completely changed patients of non-Hodgkin's lymphoma, especially of the ABC variety, which is the bad variety, where the responses to standard lines of treatment such as CHOP or even for that matter, R-DIPOC is not very high. And therefore, we came to know that polatuzumab addition to RCHP has given us much better outcomes with lesser chance of relapse and better outcomes and lesser need for the next treatment. Then, of course, there is autologous stem cell transplantation, CAR-T and bispecifics, which can also take care of patients who have relapsed post-treatment. In low-grade non-Hodgkin lymphoma, we can do MYD88 by genomics, and if it's positive, there you go. You just take a BTKI tablet every single day, and you're sorted. Previously, we had to give chemotherapy, we had to take them for transplant. Today, it's replaced by a tablet. Can you imagine this? Yes, there is a CAR-T for this also. Follicular non-Hodgkin lymphoma, we were using bendamustine rituximab. Now we can use R-CHOP, we can use Len-R, and now we've got a brilliant new BTKI called zanubrutinib, which is a tablet and it can be taken without a problem. So we've got 1, 2, 3, 4 lines of treatment for follicular non-Hodgkin lymphoma. That means we can take a follicular non-Hodgkin lymphoma for anywhere between 9 to 15 years without losing the patient. Isn't that revolution? Yes, there are bispecifics and CAR-T also for follicular lymphoma. That means even after 4 lines of treatment, if they relapse, we can still take care of them. In myeloma, we had bortezomib, lenalidomide, dexamethasone. Today, we are adding daratumumab. When isatuximab is available, we'll use that also. But currently, Dara is available as an anti-CD38. And what it did when it added to VRD, It's improved the progression-free survival, disease-free survival, and to a large extent, the kind of quality of life the patient got. It rapidly brought down the myeloma chains and therefore reduced the amount of damage to organs. That improved quality of life. And yes, we could still take them up for transplant. And post-transplant, we continued to use DARA-BRD as a consolidation to see that the disease doesn't come back. Unfortunately, if it does come back, we still have bispecifics and CAR T available for these and many more innovations, which are called cell mods, which are available. In acute lymphatic leukemia, I use the German protocol BFM chemotherapy, but today for relapse, we are using inotuzumab. And in pediatrics, blinatumomab, with or without TKI, is doing brilliantly well. And those who are relapsing in acute lymphatic leukemia, whether it's adult or child, is also doing brilliantly with CAR T. In acute myeloid leukemia, we were using chemotherapy. Today for APML, we are using ATRA with arsenox, no chemotherapy. And we are today using for the older patients, which in the past, remember, the older acute myeloid leukemias, we could not treat. We used to say, go home, especially if they were unwell or they were financially not very suitable. And we found that they were highly infected. Death rate was high. We are now giving them an option of azacitidine with venetoclax. Targeted therapy has been available through next generation sequencing. We can add it to aza-ven, such as FLT3 inhibitors, IDH1 inhibitors can be added on to be able to treat such patients. Now, my older patients also are taking treatment and they're enjoying a quality of life. They may not become curative, but at least they're getting an option for treatment. And there are some older patients who are fit. If you've got a 70-year-old gentleman or lady who's otherwise fit, why should I not give her treatment? And there you have treatment now. You'll notice AML does not have a CAR T, although Dr. Vipul is working on CAR T for acute myeloid leukemia. It's going to be a little bit difficult, but he's working on it in Delhi. So one day we'll get CAR T. What you notice from this slide that everywhere CAR T is coming up as an option. Not yet for AML, but I don't know in the future. Now, in this situation, CAR T is going to be a major game changer for us in the future. May not be upfront, everyone can't afford it, but for those who can, it might be great. What's going to be the future in terms of innovations? We are going to use microbiome modulation. That means we are going to take actually, pardon my saying so, but shit capsules, fecal capsules, we are going to use, give it to the patient to transplant the bacteria in the gut. And we've noticed it was done in Israel, I think, first time around. And what they are doing is that they are probiotics which enhance immunotherapy response and reduce infections, especially post-transplant. Can you imagine someone else's feces is going to be beneficial for you? Just amazing. Proteolysis targeting, PROTACs. There's something called as cell mods, cellular modifiers, cell mods, which we are using in myeloma, which are actually targeting the protein degradation and eliminating them or actually binding them so that the disease, the cell kill will be better. Senolytic therapy. You and me who's sitting here and talking, you who's sitting and listening, we all have cells which are dying in our blood and bone marrow. Where do these cells go? They are senescent, they have to be eliminating. So we now got senolytic therapy, which will target these senescent or dead cells, which are consuming space and nutrition, which is being used which should have been used for normal cells to grow. We eliminate those cells and give a chance for these young cells to grow. They get space and all the energy needed to grow rapidly. So senolytic therapy. So integration of these multinomics, that is genomics, transcriptomics, proteomics, and metabolics, all with clinical data for truly individualized treatment selection and real-time therapy adaptation across the dynamic disease monitoring. That means at different points of time, we can add these to the existing therapy to be able to get better results. Phenomenal revolution, phenomenal method, but it needs a lot of effort on the basis of the doctors and the infrastructure along with the patient. Yes, to translate this innovation to practice, there'll be costs involved, a good amount of infrastructure requirement. We should be able to now manage the newer toxicities which come up with these newer agents. And so we have to be trained. And these trials have to give us evidence. It is only on the basis of evidence generation through trials that we can learn optimal sequencing of these therapies, combination strategies, its effectiveness in the real world, in a hospital which is far away from where the trial was conducted, and biomarkers to see how well is this disease process doing and can we monitor the disease process. There are solutions to this through education and training, collaborative networks, and policy advocacy. Tomorrow, we'll be able to do prevention of disease by doing what is called as chip monitoring and intervention. We can find out the gene which is going to cause the damage and see whether we can eliminate the gene, especially those who have a familial predisposition for certain disease processes. We can get prophylactic vaccines and we can do lifestyle modification programs to see that we don't feed the gene in order for it to become malignant. So there'll be a lot of personalization which will take place, and we'll have to integrate this through AI-driven programs so that we can get seamless care. The key priorities for the next decade will be to be able to achieve a functional cure. We want to cure the disease. We want the patient to be off treatment. We want the patient to live a normal life. The patient has done nothing wrong to get cancer. It is not a fault of that patient to get a hematological cancer. Therefore, we want that person to become disease-free and therefore hopefully be cured. So we want to develop a functional cure, how to prevent these in the high-risk populations, ensure we give equitable global access to these innovations to patients across the strata, and use AI to help us to be able to determine which patient requires which kind of treatment, so that we can minimize treatment toxicity and maximize the benefit. So we'll want to transform chronic illnesses into cure-focused strategies so that we are rid of the disease process. And through MRD, we can decide, does he need to continue treatment or does he need to stop and then restart if there's a disease process recurring? So we can do all these through functional cure metrics through MRD status. So my key takeaways and conclusions for our discussion today is that the future is now. If we start thinking today, future will happen. Future is now. We are at an inflection point where precision medicine, immunotherapy, and molecular monitoring converge to redefine hematological cancer care. The milestones that we've achieved of diagnostics, therapeutics, targeting therapies, and therefore improving the survival, including through judging treatment decisions through MRD, is with us today, and it will be more refined tomorrow. And I know there are, because of time, I cannot speak about them, but I know that there are several other methodologies which I have not discussed here, which are in place in early phases to look at how we can diagnose better and control disease better. So we'll be able to, with the help of AI, do much better in terms of risk stratification, getting functional cure, and give access to the best lines of treatment across the various stratas of our society. So my conclusion would be treatment of hematological cancer, which was my topic. Treatment of hematological cancer has undergone a revolutionary change in diagnostic and therapeutics for the better outcome of patients. And again, I say my hero still remains diagnostic laboratories, which are making a huge impact in the way we are treating cancer patients. I thank you very much for your patient listening. I hand it back to Dr. Sanjay Gohil.
Yeah, thank you, sir, for this insightful and excellent talk. You have given us a fascinating overview of how science and clinical innovations are converging to redefine the outcomes in hematological cancers. Thank you for that. Now we have some time for questions and discussion. So I invite the audience to share their questions in the chat box. So, sir, there are a few questions in the chat box. I think most of them you have already covered in your talk. But if anything specific you would like to answer, then I'll just share.
It's in the chat box.
Yeah, yeah, I'm just sharing. Given the rapid emergence of the novel therapies, what do you think future role of stem cell transplantation in the management of hematological malignancy? Will it remain central or it will become more selective?
Thank you, Dr. Kothari. It's a very nice question. And I think I've answered it, but I'm happy to give more insight in this. I think your last line is the most perfect line. Will it remain central or becomes more selective? That's a very good way of putting it. I think it's going to be more selective. It will never go. Transplant is the only curative option. Remember, all these immunotherapies still have the chance of disease recurrence. Even stem cell transplant is not always curative. You can get a relapse even post-transplant. But as of now, curative option stands only with stem cell transplantation. But I'm hoping as time goes along and we understand diagnostically diseases better, where we able to target from different angles disease process. And like how Dharmendra ji says, chun chun ke marunga, we will also have targeted therapies which will specifically attack only the disease process, only the malignant cells, and eliminate that without harming the normal cells. That's going to give quality of life. That's going to give targeted therapy, which is going to make a difference. Whether that will ultimately turn into cure, time will tell. Till then, transplant is our best option. Otherwise, it should be more selective. But if in the past transplant was used for indiscriminately for large number of people, today is going to be more discriminatory in its selection, and therefore it's going to be more selective. So I agree with the last line.
Yeah. Thank you, sir, for that answer. I think it clarifies the role of stem cell transplantation in future also. So, second question is, how do you foresee the integration of novel agents like biospecific antibodies, antibody drug conjugates, and next generation BTK or BCL2 inhibitors within existing treatment paradigms? Will
Okay.
they complement or eventually they will replace the traditional chemotherapy?
Thank you for that question again. So as of now, if you see in my practice today in CLL, when a patient of CLL comes to me, because that's where BTK inhibitors are used maximal, um, I give them the option, do you want a continuous treatment? Do you want to have a 2-year treatment? Do you want a 1-year treatment? So infinite versus finite. Finite is injection tablet or tablet alone. Let me just qualify this. If you take a BTKI, such as say the 3 BTKs that we have available to us, if you use that, right from ibrutinib to acalabrutinib to now availability of zanubrutinib, they have to be taken long term. You cannot stop it because they're not curative. They will disease control, but the disease exists. If you stop, it's likely that the disease will come back. So I can make you visualize lawn mowing. You mow the lawn, everything looks nice, everything looks beautiful. You stop lawn mowing and everything grows back. So BTKI will be continuous therapy. The same BTKI, when you combine it with a BCL2 inhibitor like venetoclax in an oral form, we can use it for 2 years. And at the end of 2 years, we can do MRD, which I told you about. And if the MRD is negative in the blood, we can do MRD in the bone marrow. And if it's negative in the bone marrow also, we can get off the drug. So the BTKI, which was continuous, if combined with the BCL2, now becomes limited. Last, in finite therapy, I've got a combination of a new drug called obinutuzumab, which can, along with venetoclax, that is a BCL2 inhibitor, be used over 1 year. The injection is given for a period of 6 months. The tablet goes on for 1 year. At the end of 1 year, if your MRD is negative in the blood, negative in the bone marrow, you're off therapy. And I've got a patient who's been off therapy for more than a year now after taking this combination. He's disease free, and I'm happy to tell you, after completion, he went on to do the Iron Man and did better than his last attempt. This is the power of revolution. This is the power of being able to give you therapy which can disease control and give you quality of life. Where the tissues are not damaged, you can go back to what you were doing. Isn't that brilliant? So yes, it can be used. Now, in terms of sequencing, if BTKI fails, or if my patient's disease comes back, I can use another combination. I can use bispecifics. In CLL, CAR-T is going to do very well. But I've got many other therapies for CLL that I can use. I can reuse the original therapy. I can add new therapies. So I'm able to control the disease very well today. So CLL today, I'm not worried. I'm able to control the disease. Remember, CLL, 80% of CLL patients are asymptomatic. They will not need treatment. It is a 20% will need treatment.
Right.
And for them, we have got enough treatment. So nothing to worry. We can give them a good quality of life.
Sir, there is one more question from Dr. Kauri. As new therapy emerge, what are some of the key challenges we face in the management treatment related to the toxicity and ensuring the quality of life for the long-term survivors?
Yeah, thank you again, Dr. Kothari. Yes, the new treatments will come with new challenges. There's no doubt about that. We are going to see different kinds of disease processes. Now, let me give you an example. One of the fears of CAR-T is that when we are using bioengineered CAR-T, it is a patient's T cell, which is bioengineered to be able to recognize the patient's own malignant cell antigen and attack it. That's how it is programmed. So it actually goes and bites and attaches to the patient's own myeloma cells, own T cells against own. So you'll say, why was it not doing it in the first place? It had got tired. It had got tired. It was not able to recognize. So when we bioengineered it, it had an enhanced ability to go and attach specifically to the myeloma cells. Still, it may also be tired. It's called energy, and it may not be as effective also. So CAR Ts is not doodh ka dhula. CAR T is not God. CAR T has its failure rates, but it is good as a modality for those who are not responding to standard lines of treatment. You've got something else, and you can look forward to one treatment option. So those who have taken CAR T will in the future, these bioengineered CAR T incite a different response in your patient. We are now seeing some amount of T cell lymphomas. Most of the time, the argument is that these T cell lymphomas have not come out of the CAR T. It is a natural consequence of patients now surviving. So we are seeing second malignancies, but previously patients would not survive. Today they are surviving. So that genetic tendency towards malignancy, which was lost in the past due to death, is now surviving because of better survival of the patient. So we are seeing new cancerous changes. Is that a consequence of treatment? Is that a consequence of genetic instability in the patient? It's difficult to mention. But we'll see different things. CAR T has ICANS and CRS in neurological problems and certain release of cytokines as a problem, which we have to face. But it's much lesser, more easily managed than chemotherapy side effects. So yes, there are different complications, but they could be better managed if we are trained better for it. Bispecifics, higher incidence of infection, causes hypogammaglobulinemia. But if we detect it, we give antibiotics, give vaccination, give gamma globulins to them, we can still take care of it. Yes, different complication, but manageable. It all needs training. So therefore, complications are different, but we'll be able to handle it if we are trained well for it. But long-term survival, the question that is asked, will come with time. We are using drugs last couple of years. We need 5 years data. To break convention and revolutionize therapy, you need to have 5 years data of your revolutionary therapy to say how good or bad was it in terms of responses, cure rates, or even for that matter, certain adverse side effects or new onset adverse events.
Yes. Sir, there are few compliments also for giving the, means for your talk and the best insights and explanation for the, new therapies and all. Last question, maybe. There is many young medical students are also there on the call. So there is one question from such, I think, young medical scientist only. Which are the areas of research or innovation you would like to suggest, which could be a step in hematological cancer treatment?
I think it's a great question. I don't know whether I'm qualified to answer that, but as a clinician, today the amount of drugs in the armamentarium I have against ALL, AML, CLL, CML, lymphomas, and myelomas is huge. Currently, as a clinician, I am unable to handle this armamentarium, especially in terms of how to place it in therapy. Because while the drugs look attractive, cost is an issue. If we were able to do more research in our country for drugs that we can get it as generic, we can make our own drugs. And in that terms, being Atmanirbhar in terms of getting better targets, I think a large number of my patients who only read all these on the net can actually use it in their real life. Just now, it's all looking great because it's available for those who can afford it. I want our research scientists and young minds to look at the same disease processes and try to improve our treatment armamentarium better. Our diagnostics are great. We are fantastic in diagnosis. There's no doubt about it. And if we don't have it here, we are able to replicate it easily. It is the treatment drugs that is hard. So the Indian generic pharma is brilliant. They are Indian branded pharma. They are giving us great drugs. So many of our patients who are not able to avail it can now avail it. But then they have to wait for the patent to expire, or they have to then if our research minds can apply their minds and look at how we can create our own drugs, why are we dependent on research from foreign countries? I would love that. If they can do that for the existing drugs, that's very good. In non-hematological diseases, there is a huge lacuna, huge gap of drugs which are not available. But then, not being cancerous, they are not getting as much value as cancerous drugs, because I think everyone wants to concentrate on cancers. But non-cancerous also need research and drugs, which I'm seeing is missing. We are seeing a lot of changes in hemophilia, in PNH, and in hemophilia, we're getting better factors. Again, thanks to the government's efforts, we are getting factors available to us. So it is good, but it has to get better, is what I want to say. So young minds should concentrate on research to be able to get better drugs. I hope that answers the question. I don't know.
Yes, sir.
I don't even know whether I'm qualified to answer this, but I thought I'll give my thoughts.
And sir, how you see the role of haploidentical, stem cell transplantation in the
Huge. Huge, because not the single parents with a single child. So if they have got the child has a disease, or the one of the parents has got a disease which can be treated by transplant, where do you get a sibling? Now, if you don't have a sibling, then basically the concept is you need stem cells which are matched. We do a full house match, which is A, B, C, DR, DP, DQ. So we need about 12 antigens to match. And you know that the child will have half from the father and half from the mother. So they'll never be 100% match. Therefore, haploidentical has become very important. And now we've got protocols where we can do such haploidentical transplants. And they are doing very well, let me tell you. So we've got success rates in haploidentical transplant for various hematological diseases where the chemotherapy was not working or has worked inadequately, or the patient is unable to access newer innovative therapies, then transplant has worked and to cure in some patients. So I think it's a great modality, and it has become great because of revolutionary conditioning regimens towards that haploidentical transplant. So I think that's made a huge difference to outcomes. So yes, haploidentical is here to stay for certain selected patients.
Sir, any case where the haploidentical transplant is failed and there is a role of any CAR T cell therapy, means post haploidentical transplant?
After a transplant, there's always a role of CAR T or bispecifics, say in leukemias or in lymphomas, or for that matter in myelomas. But you need to do trials. Conceptually, yes, it can work. You have to just see to it that in the relapse state post-transplant, is the antigen against which your drug is working, is that being represented on your tissue? So if you've got a disease relapse where that antigen representation is less and some new antigen has now caused that relapse, then using an existing targeted therapy may not be as effective, may not be as valid. So you'll have to look at the genomics of the relapse to determine whether these drugs will be helpful or not. But I suspect as time goes along, it will be helpful. But trials will tell us that.
Sir, I think in the interest of time, one last question from Dr. Pankti. Cutting edge therapies often come with substantial cost. How can we balance the innovation and equity, ensuring patient in resource limited settings also benefits from these advances in the medical science?
So thank you for asking that question. If you look at CAR T, we now have Indian CAR T. And I'm very happy to tell you that Tata Memorial Hospital conducted its studies in acute lymphatic leukemia and pediatrics, and they've got great results. They published it, and our bad reactions are very less in our indigenized, humanized CAR T. That's where the difference is. We've already got it commercially available for lymphoma and leukemia, and soon it will be available in myeloma.
Oh,
So myeloma trials are going on. So it's going to be more affordable as more companies get involved. There'll be competition, cost will come down, I'm hoping, and it is definitely amenable, no doubt.
I think, sir, that is, I think, our last question from the audience.
Yeah,
Uh,
Dr. Gohil, I also have to leave this room because
yes, sir.
team
Thank
is
you.
waiting to come
So,
in.
on behalf of the audience and Metropolis CSR team, Metropolis Healthcare Limited, I would like to sincerely thank Dr. Abhay Bhave sir for joining us today and sharing his vast experience and knowledge with such clarity in the depth. And to all my medical colleagues and participants, thank you for taking the time to be here with us. I'm sure today's session has given us all some meaningful insights and key takeaways to reflect on. So stay tuned for our upcoming sessions and we hope to see you again soon. Thank you once again, everyone, and have a great day ahead. Thank you.
Thank you. Thank
Thank
you.
you. Thank you. Thank you.